In this episode of the Nurse Practitioner Podcast, Dr. Wendy Wright discusses improving vaccination rates in older adults. What was the impetus for you to do this project?
Thank you for that question. The impetus for me to do this project on improving vaccination rates in patients 65 years of age and older was actually a project that I had conducted myself in my clinic approximately 3 to 4 years ago. And about 3 to 4 years ago, what I did was I partnered up with a university in Boston named Simmons University. They sent me a couple of master's students who were really looking to do some work and to do some projects for their capstone. I brought them into my clinic, and what they did was they collected the rate of vaccination rates in my clinic in patients 65 years of age and older. And when I found that the rates that we had in our clinic were so robust and exceeded not only the national guidelines, but also the Healthy People 2020 objectives, I thought, you know what? We're doing something good in this clinic. I want to see if I can, in a 45-minute to 1 hour intervention, improve the vaccination rates in other nurse practitioner-owned clinics. So that definitely was one of the reasons I decided to do it. And then the second reason is that as we are really moving into a pay for quality type care model and away from paying for quantity, and that's really where we're going in this country, I felt like if I could set some things in place in nurse practitioner clinics so that they could then improve their rates, it would go a long way to really helping out these nurse practitioner entrepreneurs in terms of reimbursement.
I see that vaccination rates improved. Most of them were statistically significant. What do you believe was the reason their rates really improved?
So I think that there are a number of reasons that we can take a look at to see why their rates improved throughout the 3 months of this project. The first and foremost was these NPs and their staff were really motivated. They really wanted to see if they could improve their vaccination rates. And, you know, they knew me. I know they wanted to help me out with the project. So I think that they were motivated. But I think that there are some real other important takeaways for our listeners today. Number 2 was if you don't know your vaccination rates, you're not going to improve. And what I mean by that is, you know, we often think when we're in the clinic that we're doing so great at whatever metric we're actually looking at, and many of us are until we actually run our rates. And then what we find is, yes, you know, we're good in the people that come into the clinic, but we're not so good at finding ways to get people into the clinics to get those vaccinations done. So I think number 2 was running those vaccination rates, which is really essential so that you then have a metric upon which you can improve. Number 3, I taught every nurse practitioner and their medical assistants and their nurses best vaccine practices. And what I mean by that is things like every time these people walk through the door, look at their vaccination records. Because if we only wait for well visits to immunize people, we are going to miss lots and lots of opportunities to vaccinate them. Number 2, what we need to do is we need to discuss these vaccines with what we call a presumptive approach. And a presumptive approach is, I'm presuming you're going to take these vaccines today when I offer them to you. There's 2 different languages that we can use with patients when we're discussing vaccines. One is presumptive. I presume you're going to take them. So an example of that would be something like, you're due for the pneumococcal vaccine today. I have it here in the office. Let's get it on board. That's a presumptive approach. So the other example of language that people often use when they are talking with people about vaccines is called participatory. An example of this would be, how do you feel about receiving the flu shot today? We know that when we use presumptive language, the likelihood of getting our patients to get that vaccine today significantly improves. So I think that's another factor why the rates improve so substantially. The next reason, I believe, is because what I did was I helped these 4 clinics that I was looking at. There were actually 4 in the study. We refer to them as 2 clinics because 3 of them were owned by the same owner, and patients kind of moved back and forth among clinics. So I wasn't able to separate out my samples based on clinics. But there were actually 4 nurse practitioner clinics that I worked with. And what I helped them to do was to set up billing for Medicare patients, to bill vaccines. Because for patients who have Medicare, billing out vaccines is very complex. The pneumococcal vaccines, the flu vaccines, those vaccines are actually covered under what's called Medicare Part B, which is the type of Medicare that covers office visits. But it's the shingles vaccines, also known as the herpes zoster vaccines, and the Tdap vaccines that are actually paid for under Medicare Part D. D is historically a pharmacy benefit. So in order to bill that out, nurse practitioners or any provider for that matter has to set up a special billing account with Medicare in order for that to occur. So I not only taught them about vaccines and best vaccine practices, but what I also did was I helped them to set up appropriate billing and taught them how to bill and code for vaccines. And then last, I talked with them about making sure that they're setting reminders such that if a patient refuses a vaccine today, that vaccine can be revisited tomorrow. Or when the next time that patient comes in. So I think that there were a multitude of reasons why we saw such statistical significance. They were motivated. We ran the numbers. They employed best vaccine practices. They used presumptive language rather than the other types of language that I've spoken with you about. And last, they learned how to bill and code for these vaccines.
Why are vaccines in the older adults so important?
You know, we are an aging society. Today, there's about 49 million people 65 years of age and older living in the United States. But by the year of 2030, that's going to be 1 in every 5 adults will be over the age of 65. And by 2035, that number is projected to be 78 million. So I think the fact is that we are an aging population. We've got to make sure that we are protecting this aging and what I call a vulnerable population from as many of the vaccine preventable illnesses as we can. We also know that people over the age of 65 are more likely to have chronic diseases, conditions like diabetes and kidney disease and liver disease and rheumatoid arthritis, conditions that make them more vulnerable in the event that they do get conditions like influenza, herpes zoster, or even other conditions like invasive pneumococcal disease. Also, older adults are less likely to mount the same type of immune response from vaccines. So we know that it's really imperative that if a vaccine is indicated to be given, let's say at 65, it's much better to give it at 65 than it is to wait until these people are 80 and 90 when they may not mount the same immune response. So I am a firm believer that vaccines don't end in childhood, that that vaccines need to be offered throughout our entire lifespan. Because if you look at the population that develops herpes zoster, or also known as shingles, if you look at the population that develops invasive pneumococcal disease, or the people that die from influenza, it is often our older adults. So protecting this vulnerable population is really imperative. You know, one last comment I would say to you is that every year in the United States, 50,000 people die from vaccine preventable illnesses. 99% of those occurred in adults. And when we look at people 65 and older, 300,000 people are hospitalized every single year in this country from influenza, and 23,000 die from that complication. So there's a lot of opportunity to immunize this vulnerable group and to make a huge impact in keeping these individuals as healthy as we can keep them.
I understand that Medicare doesn't pay for tetanus and zoster vaccines. Is this correct?
Well, this is in fact not correct. And I'm glad you asked me this because there's a lot of misinformation out there. I've already explained to you that influenza the pneumococcal vaccines are paid for under Medicare Part B. But the Tdap vaccine, also known as tetanus, diphtheria, and acellular pertussis, as well as the herpes zoster vaccines, Zostavax and Shingrix, the two shingles vaccines, are actually paid for under Medicare Part D, as in dog. So Medicare does cover it, A, provided that the patient has a Medicare Part D plan. See, in this country, Medicare Part D is optional. It's an extra expense for our older adults, which means there are going to be some of our patients that are not going to opt in to that Medicare D plan. So let me tell you what I do in my clinic, and it might make it a little bit easier for everyone to understand. So when I see a patient on Medicare who comes into me, and I look at their vaccine record, and they're due for a Tdap or a herpes zoster vaccine, either one of them, what I say to the patient is, Mrs. Smith, you're due for Tdap and Shingrix today. Are you interested in those two vaccines? Mrs. Smith says yes. My next question to her is, Mrs. Smith, do you have a Medicare Part D plan? Oh, yes, I do. Okay, great. So what I say to my staff is, can you please put Mrs. Smith into the Transact RX system? They put her name, her date of birth, her Medicare number. They hit query. And what it will do is it will query Medicare Part D, and it will look and say, yes, Mrs. Smith does have a Part D plan, and she will be liable for $25.38 today for both of those vaccines. I then go back into Mrs. Smith and I say, Mrs. Smith, you're going to be responsible for $25 for both of these vaccines combined. Is this something you'd like to get? And if she says yes, I give her the vaccines while I've got her there. So there's this misperception out there that people who work in offices, urgent cares, specialty clinics can't bill Medicare Part D. We absolutely can. We just need to make sure that we sign up with a system like Transact RX. They will bill Medicare Part D directly for our clinics. And that way, what we can do is we can give that patient those vaccinations while they're on site. I think that really goes a long way to making sure that these patients get their vaccines. Because if they have to go to the pharmacy, they often do not do it. And even if they do go to the pharmacy, I struggle in my clinic to get documentation from the pharmacies that they've actually done it. So this is another way that we can all work together to improve the vaccination rates of patients over the age of 65.
What can NPs do in their clinics to improve vaccination rates?
So I think that there are a number of things that people can do in their clinics to improve vaccination rates. And I often will set this up by saying the first thing we need to do is eliminate barriers that exist to getting our patients that are 65 years of age and older. One of the things we can do is look at vaccines at every visit. What we do in our clinic is we have a care planner. And this care planner plans every visit for the nurse practitioner before the patient comes in. So they look at the schedule, they pull up the patient's vaccines, what they've had, and they write on a sheet what vaccines the patient needs. We find that by doing that, it's another set of eyes in that patient chart so that when that nurse practitioner walks into the room, they already know what vaccines the patient's had and what vaccines they likely are going to need. Number two, stocking vaccines in your clinic is essential. Again, if patients have to drive 20 or 30 miles to get a vaccine, they're often not going to do it. Setting up systems which enable you to bill Medicare Part B, such as the Transact system that I just spoke with you about, can be very beneficial to getting these folks vaccinated. And then employing best vaccination practices in your clinic. Running your rates is essential. What we also do is we have a vaccine champion in our clinic. And that vaccine champion, it is their job to bring back the latest information on vaccines to all the providers and all the staff of the clinic. And that way we know that we're all up to date with the latest information and recommendations on vaccines, because it's very difficult to stay up to date with everything that we need to stay up to date on, particularly in primary care. As I told our group and our audience earlier, your language matters. use that presumptive language. Don't ask them if they would like to talk about the flu shot today. Say to them, you're due for the flu shot today. I've got it here in the office. Can we get this on board today? And when we stock those vaccinations and when we build them, it's going to go a long way to getting them in the arms. And the last thing I would say is, if a patient refuses a vaccine, use the Z28.21. That's the ICD-10 code called vaccination refusal or vaccination not carried out because of patient refusal. It's called Z28.21. Put that in your note. And that way, the next time the patient comes in, it is in your notes that there was a refusal before. It serves as a prompt to make sure that these patients are reminded at that next visit that they need those vaccinations. I think these are some really great strategies. And I would invite our audience to take a look at the article that was featured in the Nurse Practitioner in April. I think you will find that there's a great table in that article where I actually discuss best vaccine practices and things that offices can do to try to improve their own vaccination rates, not just in people over 65, but across the entire life spectrum.
If our audience is interested in taking on a project like this, where can they start?
Thank you for asking. I think you can start with something as simple as asking your practice manager to run your immunization numbers, or ask your practice manager to give you 20 names or medical record numbers of patients 65 and older in the clinic, and you randomly go into their vaccination records and take a look. Are they up to date for Tdap, PCV 13, PPSV 23, the shingles vaccine, the influenza vaccine? And take a look, even with just 20 charts. How are you doing with those 20 charts? And if you find your numbers are not where they need to be, Healthy People Objectives 2020 says we should be at 90% for our pneumococcal vaccines, our influenza vaccine, and at least 30% for our shingles vaccines. If you're not there, use some of those strategies that I've spent this podcast talking with you about. I think you will find that simple changes in the office and a coordinated effort among all of your staff can really improve your vaccination rates. Again, not just in people over 65, but across the entire lifespan. In today's environment, we have got to be doing everything we can possibly do to improve our vaccination rates. We're hearing about outbreaks of measles today, and many of those patients are unvaccinated. When we hear about deaths from pneumonia or deaths from invasive pneumococcal disease or influenza, these patients are often unvaccinated. So I think it's imperative that we do everything in our power to try to improve our vaccination rates. And I'm very appreciative that you've, A, chosen to interview me today, and number two, that you've given me the opportunity to talk about something that I'm really very, very passionate about. I hope I've given our audience some really good tips to try to improve their vaccination rates.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.